Welcome, everybody, and thank you for joining us for today's session. First, I would like to introduce myself. My name is Elizabeth Hermsen, and I am the head of Global Antimicrobial Stewardship and Health Equity in Infectious Diseases at Merck. And I would also ask my co-chair, Rafael, to introduce himself at this time.
Thank you, Elizabeth, and welcome everyone. I'm Rafael Obregon, country representative for UNICEF in Paraguay, and I have been co-chairing this workshop along with Elizabeth and other colleagues in the forum. So really pleased to have you on board today. Over to you, Elizabeth.
Thank you, Rafael. So I'll start with a few acknowledgements. First, the leadership of the Forum on Microbial Threats, and that includes Peter Daszak, the chair of the forum, and Kent Kester and Rima Kabaz, the vice chairs of the forum. I'd also like to acknowledge the forum staff, Julie Pavlin, Charlie Minicucci, Claire Biffle, and Julie Lau. And then there should be a slide showing the sponsors of today's session as well as the forum. And I lastly would like to acknowledge the planning commitment and the planning committee and the time commitment that they have put into putting together this session today, as well as the summer sessions that we'll talk about a little bit later. To provide a little bit of background, the Forum on Microbial Threats was formed in 1996 at the request of the CDC and the NIH to provide a neutral, structured opportunity for stakeholder discussion and scrutiny of critical scientific and policy issues to address the threats that infectious diseases pose to communities around the world. The forum has hosted discourse on the most effective ways to understand, anticipate, and address emerging infectious diseases through a range of topics, including the 2014 Ebola epidemic, to the interconnectedness of infectious diseases and non-communicable diseases. Today's session is part of a larger workshop series designed to evaluate the broad impacts of the pandemic on human health and global development, and critically examine what has and has not worked around the world in responding to the COVID-19 crisis, with an eye toward informing resilient recovery and better preparedness for future outbreaks. Today, we are going to focus on the multifactorial nature of COVID-19 through a syndemic lens, and using that lens to start identifying cross-sectoral areas of concern. The opening presentation by Emily Mendenhall will further describe the syndemic concept. Subsequent sessions to be held this summer are yet to be determined, but some of the potential broad topics include breaking the cycle of the fire and forget style of crisis response to public health emergencies, and COVID-19's impact on infrastructure, global supply chains, and indirect effects on health, such as child and adolescent development and mental health. Of note, the webinar today will be recorded, and videos of the presentations will be archived on the forum's website. There is a Q&A bar at the bottom of the video player that you are viewing, but it is not visible if the video player is in full screen. So with that, let's jump into today's webinar. It is my absolute pleasure to introduce our moderator, Laura Helmuth, who is the editor-in-chief of Scientific American and a member of the National Academies Standing Committee on Advancing Science Communication. Her full bio can be found in the briefing book, along with those of the other speakers and planning committee members. Thank you again for joining us today. And Laura, over to you.
Thank you so much. And thank you to Elizabeth and Rafael and to the rest of the Forum on Microbial Threats for creating and co-chairing this workshop series. And I want to thank the National Academies for all the work they've been doing during the pandemic to provide trustworthy, accurate, updated information, and to use their convening powers to bring together people with different areas of expertise, show how that expertise is relevant for containing and controlling and understanding the pandemic, and talking across disciplines. I think they've just done outstanding work all year, and I'm really delighted to be able to help moderate the discussion today. So the experts who speak with us are understandably quite busy since they are helping respond to the greatest health catastrophe of our lifetimes. So we're not entirely sure who will be here for the panel discussion, but it should be a lively discussion no matter what. And part of this depends on the audience too. So thanks very much to all of you for joining us. Please do submit your questions. We're eager to hear what's on your mind in your responses to the keynote speech and in the panel discussion that follows. And then we'll have audience Q&A at the end. So feel free to ask the questions at any point, and we'll collect them and finish up our time together asking the questions that you want to ask of the panelists and the speaker. So today we're going to focus on the COVID-19 pandemic as a syndemic. And for anybody who isn't familiar with that term, it's a really powerful concept that tries to capture the fact that a pandemic isn't just about the characteristics of the virus, but about the ecosystem into which the virus is spreading. So a syndemic is a pandemic that's amplified and fueled by social and biological and even political factors, including systemic racism, previously existing health disparities, xenophobia, misinformation, and more. And we're very fortunate today for our keynote speaker to start this conversation. We have Emily Mendenhall, who's one of the world's experts on syndemics. And she is the Provost Distinguished Associate Professor in Science, Technology, and International Affairs at Georgetown University's Edmund Walsh School of Foreign Service. She has written dozens of articles and books at the boundaries of anthropology, psychology, medicine, public health, and disease. And she's led a series of articles on syndemics in The Lancet. And in case you haven't seen it, she had a really interesting exchange in The Lancet this fall. Richard Horton, who's the editor-in-chief of The Lancet, had a really powerful piece saying that COVID is a global syndemic. But then, as she pointed out in a response, it's not a syndemic everywhere, and it doesn't have to be a syndemic. Some countries have prevented it from becoming one, but in the United States and in a lot of places around the world, it has become a syndemic. And it's really important to understand where it is and where it isn't one, and what can we learn from that, from lessons from around the world. So I want to thank very much Emily Mendenhall for speaking with us today, and we'll turn it over to her. Thank you.
Great. Well, thank you for the warm welcome and for this opportunity to spend a moment with you in this virtual space. Let me pull up a few slides, and I will spend some time talking about what a syndemic is, what syndemic thinking does, and how it relates to the current ecosystem in which we're in. So the idea of syndemics brings together this idea of synergies among clustered epidemics. So very rarely is one disease ever experienced in isolation. We live in complex worlds, societies, and even our bodies are so complex. We experience multiple conditions, underlying, visible, invisible, in everyday life, and some of those are social. So how we experience disease can be profoundly impacted by stigma, by the stress we hold in our bodies. So how we think about disease also is complicated. And the idea of the synergies among multiple factors that cultivate, create, perpetuate the clustering of two or more epidemics is crucial and central to this idea of what is a syndemic. Syndemics are related to epidemics. And I like to make this point here. And as was just mentioned, I emphasize that syndemics are not related to pandemics, rather epidemics, because they're locally driven and the experience and clustering of diseases are different from place to place. But the idea of a syndemic is inherently embedded within this epidemiological concept of how diseases move through and embed with or across populations, linked to epidemic, pandemic, endemic. So really it's situated within this kind of conceptualization, of course. So what makes something syndemic? I like to think of these three sort of tacit rules when I think of or try to see if something's syndemic, because not everything is, of course. So number one, I look at, do two or diseases cluster within a population? And this relies heavily on studies from epidemiology, on comorbidity, multimorbidity. Do we see the diseases that are clustering? Where are they and what are they? Now, the second rule is once we see the diseases that are clustering, do they have some sort of critical interaction? Now, this isn't necessarily an interaction that we think of when we think of, social epidemiology or epidemiology. What I'm talking about here, is there an interaction at the biological level? Is there interaction between inflammation and glucose control? Is there inflammation between psychosocial stress and the body? So is stigma is a good example of a social interaction. So I found that in my work in South Africa and Kenya, people who are diagnosed with diabetes may keep that disease secret, in part because it is imbued with other stigma linked to HIV. So people may say, actually, you're just saying you have diabetes because you're seeking this chronic care when actually you have HIV. And this is something that's come up a lot in my research. So there is a component in which stigma or interactions between diseases at the social level actually affect the disease outcome at the biological level. So the third rule is that structural and social factors precipitate this clustering of diseases. So this can be as historical, as genocide, enslavement, structural violence, as well as ongoing social factors, such as microaggressions, racism, medical racism, social stress, trauma. I work a lot on interpersonal violence, which is very strongly embedded, but it can also include things like immigration policy and how that influences how people move, interact, seek or avoid care. So these are fundamental things. So of course, if you boil it down, we look at clustering, we look at interaction, and we look at drivers. This is the model from the Lancet paper led by the architect of syndemic theory, Merle Singer, who first started thinking about syndemics in the early 90s when he was responding to HIV with the Hispanic Health Council. And this model looks at basically the conditions that promote the clustering of the diseases, their adverse interactions, and the enhanced kind of conditions or disease because of those interactions themselves. So it's important to think about how these interactions work in this way. And we actually, one of the critiques of syndemic theory has been that actually looking at, measuring, and seeing the interactions are complicated. And we have a new special issue in social science and medicine that has been deconstructing what that means and what that looks like, hoping to move the work further along by looking at, can we measure the impact of sugar sweetened beverage policy, for example, on the outcomes of clustered diseases? So these are kind of questions we're looking into. So the first study that came out, as I mentioned, was by Merle's work looking at HIV, and what he looked at in the inner city poor in Hartford, Connecticut, was how his work on HIV could not be dissociated from violence and substance abuse. And this is the bread and butter of medical anthropology, really thinking about how critical structural and experiential dimensions affect how people get sick, where, and why. And this work in Syndemics was a way to translate ideas from anthropology across disciplines. Merle is inherently an applied anthropologist who's engaged with multiple disciplines, but also really concerned with interventions and how we think about what we do as anthropologists matter to implementation and what that looks like. And not just implementation at the clinical level, but also at the policy level, also at the political level, and how we can understand what upstream interventions and clinical interventions do to mitigate the experience of illness or disease. So his first work on SAVA, substance abuse, violence, and AIDS, was looking at the overlaps of what these illnesses do and what they are in people's lives, how they become, what drives them. And you can see here, I've kind of reconstructed one of his early models. And often his first model was actually, and you usually have this, it disappeared, is a triangle. So thinking about the triangle and putting syndemic in the middle as looking at, you can't understand HIV in this population without thinking about the impact of violence and the impact of substance abuse and what drives HIV and how people experience it and talk about it and live with it and survive with it or don't, and what that means. So this work had a huge impact on me. This is my first book almost 10 years ago now, but this was my dissertation work when I was studying the experience of trauma and diabetes among Mexican immigrant women in Chicago. And what I found, I did 121 interviews, spent about 6 hours with each person, each woman, and we basically talked through their life history. And what I did is I just asked people to tell me about their lives and start with childhood. And, you know, many women it was one of the only places they had to just talk and feel and share. So they talked for hours. And from those interviews, I deconstructed what mattered in their lives, what caused them stress, what memories they held close, how did that make up how they defined their experience. And what all these women had in common is they were women of Mexican descent. 2/3 were born in Mexico. And about that many preferred to speak English or Spanish over English. And about 1/3 were born in the US, although there were different numbers, but I was looking at what women defined on their own terms as causing or inflated in their illness. And all of the women also had type 2 diabetes. So what I found is when I asked women about the diabetes, they wanted to talk about different types of trauma, especially linked to violence, to specific instances of rape or interpersonal violence, mostly during childhood or early marriage, and also immigration or isolation linked to immigration policy specifically, but also this deeper nostalgia or basically missing sisters and mothers in Mexico who they couldn't visit because of immigration policy, and how they felt isolated, even though they loved being with their families in Chicago, how they felt this isolation and fear, and how these could not be dissociated from distress, from depression, anxiety, but also diabetes, and how all of these were inbound in their experience. And very quickly, I could not define this study as one of diabetes or of trauma itself, because these experiences were so closely bound. And a quick oversimplified narrative is Maria, who is a woman who I interviewed 2 times, once in 2007, once in 2010. And in 2007, she revealed this extraordinary trauma, this abuse as a child, and this abusive husband, and feeling unsafe and having out of control diabetes and pretty out of control depression. And because she suggested suicidal ideation, I brought her to meet with a psychologist, and we went through all the forms, which took hours. And she saw a psychologist who was Spanish speaking, so could serve her where she was at the clinic at Cook County Hospital where I was. And they, after 2 years, or 3 years, I guess, when I saw her again, her depression symptoms were gone. Her diabetes was well controlled. She left her husband and was living on her own for the first time in her life, and was employed. And this is an oversimplification, but that was a radical kind of recognition of getting to the root. She had done actually counseling for 2 full years. And that is an example of how getting to the root of her trauma can be an extraordinary sense of recovery, and can be an incredible way to overcome this syndemic suffering. Oops. Oh, why can I not do this? Okay. So when Richard Horton started writing about COVID as a pandemic, as not a pandemic, but a syndemic, my ears perked up, because in 2019, there was a Lancet commission that suggested that climate crisis, food, and agriculture, and malnutrition over and undernutrition were indeed a global syndemic. And I understand where they were coming from, because you can't really understand the agricultural industry and food production without thinking about climate, and without thinking about how much food people have or do not have. But I argued with Merle at that time that, in fact, that was a misnomer, that a global syndemic is an oxymoron, because you can't say that something's global when there's such local implications. And so when Richard Horton wrote that COVID-19 was a pandemic, I said, this is actually a pretty important thing to think about these interactions, but indeed it's not global, because context matters in such a profound way. Because when we call something a global syndemic, we erase the histories of inequity, in our case in the United States, of genocide, of enslavement, of ongoing housing segregation, of education policies, and all of these things that have structured who gets sick and why. and really thinking about context as driving the clustering of diseases matters, as well as politics and social dynamics. And this is something we've seen with COVID-19 so profoundly, and I think why Richard Horton was really emphasizing the syndemic nature of the disease. But of course, we need to look at context as different. In the United States specifically, Lance Gradley wrote this great piece on systemic racism, chronic health inequities, and COVID-19, outlining the role of political leadership and these historical forces and how people think about and produce ideas of risk in the US, and how that affects how people move, and how some people care and mask and stay home, and how others don't, and what that risk means, and what becomes imbued in what is risk and what is infection, and who dies and who lives. So we know that the case of New Zealand is the opposite of the United States. When Ardern responded, the Prime Minister responded, which is with such a strong response, closing things down, and really with a compassionate, charismatic leadership that we did not see in the United States. And this compassionate leadership really emphasized the need to care for each other and follow these social policies. And so this was, of course, the extraordinary antidote to the US experience, where a strong national response prevented a syndemic from happening at all. So of course, in New Zealand, there was no syndemic. Now in Germany, they also had a stronger response, and they had a lot fewer deaths, and people followed the kind of leadership around how to respond to the pandemic differently, which had a lower impact specifically of COVID in the population in Europe. Oops. And furthermore, it's also important to think about how people have been constructing and talking about COVID in sub-Saharan Africa. There's been a lot of racism and racist thinking about how people have been affected in sub-Saharan Africa. And I was on a call with some colleagues in Rwanda the other day, and I'm writing a book on the experience in rural Iowa because my brother-in-law led the response. I spent last summer there and did ethnography. I was telling them about how it's called shame and how people didn't really respond to politics because there was no national leadership or state leadership in that case, because personal responsibility was the status quo. And she said, well, you know, it's interesting because we had such strong leadership in Rwanda and have had such a muted infection rate, and people really came together in a profound way. And it shows how political leadership and how people structure the response had a profound impact on how the disease traveled in the population, who got sick and why. And of course, the disease profile. And although diabetes kills more people than HIV around the world today, in places like Rwanda, or where I do a lot of work in South Africa, well, South Africa has had a lot more infection, of course, but the experiences are different, in part because of the epidemiological profiles and the political leadership and what that means and what that's done. So I wrote early on, about a year ago, that social policies are going to make coronavirus worse, and this definitely played out. But we really, the point I make at the end of the piece is we really need to think for future. I mean, we had a pandemic playbook that was dismissed at the beginning of the pandemic, but how do we implement and deploy these pandemic policies from the beginning to really ensure that that syndemics don't occur, for example, that the infection doesn't go wild and then affect those who are most vulnerable? And also, how do we care for each other? So why do syndemics matter? Let's see how much time I have. Syndemics matter because they change the way we think about disease. I like syndemics in partly, I think it's pretty related to ideas that, you know, Edwin Chadwick wrote about in the 1850s in London, about how poverty and inequality kills more people than murder, right? How do we measure that? How do we think about that? Those questions are consistently how social epidemiologists have been thinking about, and, you know, anthropologists and sociologists have been thinking about illness and disease for a long time. But using the word syndemic engages across disciplines and is something that's actionable. Something about thinking about synergies in epidemics is imperative about how we think and what we do. Also recognizing that diseases rarely live in isolation, how and what social, political, and economic ecological factors drive poor health, where and how that differs from place to place. Also determining how co-occurring diseases, medications, social dynamics, clinical barriers make people sicker. Iatrogenic or clinically inflicted, hospital-inflicted conditions certainly play a role here. And thinking about, for example, in the United States, over medication and not having integrated care. So having a hard time knowing which patient is taking what, especially for patients who are not able to closely monitor and understand all of the pharmaceuticals that they are taking or how physicians are speaking with them. That is a huge challenge. Understanding the most effective clinical and community-based interventions to mitigate syndemic interactions. Also recognizing how crucial social policy is and emphasizing people-centered care. We have a really long way to go, but there are pretty clear things that we can do to promote and intervene in syndemic problems. So as a transdisciplinary agenda, just a few kind of take homes, and then I'll talk about different levels of thinking about interventions. So change how people think about disease. This has been a century-long journey. Bring together multiple fields. We all need to be in this room. That's why the National Academy is taking on the idea of syndemics is so crucial. Cultivate a comprehensive view of how syndemics emerge, converge, interact, and change through time. And we have this special issue in social science and medicine that is really trying to think about how do we use epidemiological tools to really test and think about and provide evidence for why social policy or integrated care really matters and what can do. Also working from ethnography to epidemiology. I have my first big paper from this R21 NIH study looking at syndemics from the ground up. So we built tools based on ethnographic findings in Soweto, where I work in South Africa, and have tested it at the population level. And then we went back and asked more questions and spent a lot of time just speaking to people. So moving from ethnography to epidemiology provides evidence for the tools we need. Also identifying methods to identify syndemic concentrations and test syndemic interactions. How can we make this idea actionable in a way that provides evidence for why interventions matter? And also just really taking seriously what underlying interactions are happening and how do we measure them? It's very, very complicated. So often when I talk about my work on depression and diabetes, I think of upstream solutions that are broad and big, but can be so impactful. From food policies, regulating sugars in our food, improving how, really providing evidence and data about what sugars are in the food we eat. School food policy, we all know how much of a struggle this is in the United States. What foods are provided for our children and what's in it. Housing policies, desegregation, making sure that there is legal counsel available in clinical spaces that can also help improve some of the determinants of why people get sick. That's such a crucial thing. Healthcare policy, access to safe, accessible, affordable healthcare. Minimum wage policy, which is in the news and hopefully is going to be changed. Maybe also with some of this unionization, we'll see some change in collective bargaining. And then also immigration policy, which is so crucial. And, it seems to be in the news again and things get better and then they get worse. And, but really work visas for undocumented workers are so crucial and can make a huge difference even there. Then we have clinical interventions, thinking crucially about person-centered medical homes. I had my first baby in the UK and in London, although it's definitely not a perfect system. There was a surgery, a clinic in every single neighborhood. And it was so easy to go there and even drop in. This is possible in the United States. And it requires that we shift and think about medical teams that are involved with multiple systems and multiple people and, having nurse practitioners lead these community-based programs that provide people with safe places to get care that are reliable, and they can have psychologists, they can speak to a lawyer, social workers are not just processing Medicare papers, but they're actually doing the social work that they're meant to do. Also incentivizing health providers to keep people healthy, which is what they do in the UK. You get bonuses and general practitioners are paid more than surgeons in some cases, and they are incentivized by making sure that people are healthy, not by taking more tests. And then also house visits. House visits are so critical. And we're seeing a little bit of this with vaccination, which is interesting, but figuring out how to meet people where they are, which is such a crucial thing. If we really want to have social justice in health, or we want to really provide health for those who are the most marginalized, house visits, or also, going to people who are living on the streets and caring for them. And this is based off the super utilized equalizer model, which is a very interesting approach. And, but it also demonstrates how extremely unequal our system is. So community-based interventions may be more downstream and embedded in the community and community-led. So thinking about community mental health, improving access to Spanish-speaking counselors, mental health care at community centers, at the Y, having therapists at the Y can be, for example, or whatever community center people are using can be so critical. House calls are so important and something that we've lost in our society but could be transformative. Texting with counselors can be really useful. It's not the same as psychotherapy. It's not as intimate, which is so transformative, but texting with counselors and having someone on hold, not just for suicide, but for extreme anxiety, for trauma, for having recurring dreams that you can't sleep. Sleep is so essential. How do we meet people where they are? This may be useful, although it is also not always, it may be kind of complicated with smartphones versus flip phones and who has access to phones, which is also something that's not equal in the US. Peer group counseling. So there's some really great work on the Alcoholics Anonymous model and how transformative it is on how people take on a new identity and are able to heal and move beyond addiction. But this is possible for other things. We implemented some peer group counseling at Cook County when I was working there, and this was led by the physician I was working for. Not me, but we implemented diabetes groups where people who had diabetes would come together. And, you have a shared identity as someone living with diabetes, especially when they are gender matched groups. But through that shared identity, you don't just talk about your illness. You talk about your stress. You talk about, all of these things. You talk about financial literacy. And these can be really powerful spaces to recover. And also really addressing rumor and confusing messaging. Although I wrote this slide before COVID, it could not be more influential. I just published a piece on frames people use to talk about COVID, and I can share it with you, but it's from the Midwest, a white conservative and Protestant largely community. And it shows how there is a frame of concern. Many people are concerned and very careful with their families and their personal risk. Or there's constraint, people who don't want to pass the virus, but are being, kind of constrained with their businesses and trying to, kind of think about the virus, but are still needing to make money and, really implementing kind of an econ-based response to the virus. And then we have the crisis frame, which is many academics and people in public health who are like, this is a global crisis. We need to be as absolutely careful as possible. But then we have the conspiracy frame, which has taken hold in such a profound way. And the conspiracy frame is, of course, reproduced by pro-Trump QAnon, but it's also kind of reproduced by communities of moms, communities of parents, communities and faith communities. And these notions are producing, vaccine hesitancy. We know that there are different kind of ways in which people are talking about, and really getting to the center of the conspiracy theories is critical. And we know this is something that I don't need to tell you, but it is central to thinking about syndemics. And then downstream, what else can promote good health? These are just some, general examples, but women's collective groups, really providing spaces for women to come together and learn financial planning. I have a classmate from when I was in college who's now a pediatrician in Boston, and in the waiting room of, her name is Lucy Marcel, if you want to look it up, I think she has a TED Talk, but in her waiting room of her pediatric office, she has someone there who helps families do their taxes. And she's found that by helping families do their taxes, they recover enough money to provide healthy food for an entire year for their families. That is profound. Just being able to have some sort of financial literacy can be transformative. Also thinking about medical bankruptcy forgiveness and how, medical bankruptcy is one of the greatest causes of bankruptcy in the United States. It's very shameful that this is part of the American experience. And also really investing in community gardens. Community gardens is not just good for producing food, but it's so good for mental health. Getting your hands in the dirt. I know every time I get my kids out of the house and we're in the garden or we're out on the trail, I can just see them lighten, and we know this, there's plenty of evidence to show how important it is to be outside and engage with nature. And then also lay leadership, really providing small grants or opportunities for people to apply for. opportunities to define what is good for their communities on their own terms. And these can be small grants like $500 or $5,000 that provide money for snacks, for example. And that can be so important because in some ways it provides a legitimacy of that program or of those ideas or of that collectivity. So that's all I have for today. There's of course a lot more we could talk about, and I look forward to the discussion. So thank you so much.
Thank you so much, Emily. That was fantastic. Very inspiring and clarifying and insightful, and we'll have a lot to talk about. So thank you for your presentation.